Bismillah ar-Rahman ar-Rahim. Dear guest, welcome in our first CME webinar organized by the Alexandria Thyroid Association. The Alexandria Thyroid Association is the first Egyptian society launched in October 2016 and has been created for public purposes and educational purposes. The public purposes aim for raising the public patients' awareness regarding thyroid problems, their diagnosis and treatment, while the educational purposes aims for raising the clinical practice for junior staff through repeated training program, the CME courses. The ATA is an affiliated society member of the European Society of Endocrinology since September 2017, and it organized two semi-annual thyroid teams conference under the name of the ThyroAlex. It joins also through the ThyroAlex conference a lot of thyroid-related activities all over Egypt. All information about our Egyptian Alexandria Thyroid Association is available on our Facebook page, where you can find all updates about our organization. Finally, I want to aware that registration is now open for new members. And then thank you and wishing you a fruitful scientific day.
Welcome all. So today I'm going to talk about the Alexandria Thyroid Association. As you have heard from Dr. Alia, Alexandria Thyroid Association was the first thyroid-centered association to be launched in Egypt. When we first thought about the name, we were choosing between Egyptian Thyroid Association and Alexandria Thyroid Association, and we actually preferred Alexandria for two reasons. The first, because we are proud we are Alexandrians, and the second, because this way the abbreviation would be similar to ATA, the American Thyroid Association. So in some way we would be similar or affiliated to Alexandria Thyroid Association or American Thyroid Association. Since our launch, we have been interested in CME, continuous medical education, that are thyroid focused or thyroid centered. So we have organized ThyroAlex. ThyroAlex is a semi-annual conference that is centered only on the thyroid. We have only offered thyroid topics for the past 11 ThyroAlexes. We had the pleasure of hosting many international speakers, among which is Dr. Elizabeth Pearce, who is honoring us with her presence today for the third time. The two past times were in ThyroAlexes. We also had the pleasure of hosting Dr. Salman Rasfi from the UK, Dr. Colin Diane from the UK, and Roberto Negro from Italy. Now we are launching this webinar series. This webinar series is going to be a 12 webinar series for a whole year. It would be on a monthly basis. We are going to cover almost all aspects of thyroid care. So it is going to constitute a curriculum of thyroid CME. We are starting with thyroid and pregnancy. This time it is hypothyroidism pregnancy. The next one would be hyperthyroidism pregnancy. We are going also to cover the famous causes of hypothyroidism like thyroiditis. We are going to cover famous causes of hyperthyroidism like Graves' disease. We are going to discuss the effect of drugs on thyroid. We are going to discuss non-thyroidal illness syndrome. So expect much from what is coming, inshallah. Again, as Dr. Alia said, you are welcome to join the Alexandria Thyroid Association. The details required to join the Alexandria Thyroid Association would be displayed on our Facebook page. It has the same name, Alexandria Thyroid Association, and this is going to be very soon. Now I'm going to present our first speaker, Professor Elizabeth Pearce. Professor Elizabeth Pearce is a renowned endocrinologist who is interested in thyroid and pregnancy in particular. She was the past president of American Thyroid Association, the most active thyroid association worldwide. She co-chaired the committee that wrote the most recent guidelines for thyroid and pregnancy, and this was launched in 2017. She has almost 200 publications that are cited and published in peer-reviewed journals. She's going to talk to us about universal versus risk-based screening for thyroid in women and during pregnancy, the current status for screening for thyroid dysfunction. And so Dr. Elizabeth is going to address us now. Please go on.
Okay, thank you for your kind introduction. I'm going to just get into my slides here. Give me one moment. Oops. Okay, can you see my slides?
Yes, it is very
Okay,
clear.
Yes.
beautiful.
Yes.
All right, so I'm going to talk about screening and testing strategies for thyroid dysfunction during pregnancy. And want to sort of walk through this the way we'd think about any screening program. So for thinking about whether screening makes sense for any condition, the questions that are critical are, is there a reliable and readily available test to identify the condition? Is the condition common enough in asymptomatic individuals for it to be worth doing a screening program? If we identify the condition, will we actually have an intervention that we can use to improve outcomes? And then if all those things are true, is it actually cost effective to screen? So I'll walk through all those and then discuss current screening and testing practices around the world. So with regard to the first question, do we have a readily available and reliable test for screening for thyroid dysfunction in pregnancy? I think the answer is yes, with an important caveat. So TSH is obviously readily available. We can all access that in pretty much any lab around the planet. But interpretation of what that TSH means in pregnancy can be a little bit more nuanced than it is outside the pregnancy setting. And bear in mind that TSH changes over the course of gestation, that the primary driver of that is HCG. So when HCG levels are high, and they typically peak somewhere around week 10 of gestation, that will drive an increase in thyroid hormone production, which will drive a concomitant decrease in TSH. So when HCG levels are high in early pregnancy, TSH will be low, and then the TSH will tend to come up later in gestation. So if possible, the American Thyroid Association has recommended that we should all be using sort of optimally derived reference ranges for TSH in our pregnant patients. So these would be ranges that are trimester specific, that are assay specific, that are derived in your own population with your own lab, and that are derived in populations of pregnant women who are known to have no thyroid disease, to be TPO antibody positive, and to have optimal iodine intake. And I will say that as of 2020, there are almost none of these ranges in use in practice anywhere. They just don't exist. It's really hard to build these reference ranges. I don't have this in my own practice. So what the ATA recommends in the absence of such ranges is just to take the non-pregnancy upper limit of normal for TSH, especially in early pregnancy, to reduce by about 0.5, which for most of us will get to an upper normal limit of 4. So I think we have, as I said, a readily available lab value that we can use to identify thyroid dysfunction. It just has to be interpreted with a little bit of caution. And the next question is thyroid dysfunction common enough in pregnant women for it to be worth screening? And here, I think the very best data we have come from this paper published by Alex Dagnaro-Green last year. They did a meta-analysis using population-based reference ranges in pregnancy, so sort of appropriately derived reference ranges, and determined in across the data set they looked at that there are probably about 0.5% of women who will have overt hypothyroidism in pregnancy. Far more women will have more subtle hypothyroidism, so about 3.5% might have subclinical hypothyroidism if you're using sort of appropriately defined reference ranges. And then another 2% will have what we call isolated hypothyroxanemia, which would be a normal maternal TSH, but a low free T4 level. At the opposite end of the spectrum, probably about 3% of women in pregnancy, particularly in early pregnancy when HCG is high, will have some degree of hyperthyroidism. About 2% will have just subclinical hyperthyroidism, and about 0.9% will have overt hyperthyroidism. And of those women who have the overt hyperthyroidism, The majority in early pregnancy is going to be just HCG-mediated gestational thyrotoxicosis, which is something that we typically don't treat because it typically resolves on its own when HCG levels come down. So although almost 1% have overt hyperthyroidism, if you sort of take all comers among pregnant women, it's not all of those women are going to have disease that requires treatment. So if we identify thyroid dysfunction in pregnancy, and I think, as I'll argue, what we care about most would be identifying the hypothyroidism. If we intervene, are we going to be able to improve outcomes? So for the rather small proportion of women who have overt hyperthyroidism from Graves' disease in pregnancy, I think it's probably reasonable to assume that the vast majority of these women are not going to be asymptomatic. They are going to present with symptoms, and we're probably going to be able to identify them on that basis. But unequivocally, if we find women with overt hyperthyroidism from Graves' disease in pregnancy, we do need to treat them, because untreated, we know that there's a higher risk for all kinds of adverse outcomes, including pregnancy loss, pregnancy-induced hypertension, premature delivery, low birth weight, stillbirth, intrauterine growth restriction, thyroid storm at the time of delivery, which can be catastrophic, and maternal congestive heart failure. So we do want to identify these women, but there probably aren't very many who wouldn't come to attention anyway. For the larger proportion, the 2% of women with subclinical hyperthyroidism, we know from large cohort studies like this one from Brian Casey's group that actually there aren't any adverse obstetric complications known to result from just mild hyperthyroidism in pregnancy. So this is not an entity that we particularly need to identify, and it's not an entity that we need to treat. Now, on the flip side, overt hypothyroidism, the half of 1% perhaps of all pregnant women, is something that I think we unequivocally do need to treat. If it's not treated, there's a rather substantially increased risk for fetal loss, for gestational hypertension, for preterm delivery, having infants with low birth weight, and children with lower IQ. We don't have any randomized clinical trials that tell us that treating overt hypothyroidism in pregnancy improves outcomes. And that's basically because it really would not be ethical to do such a trial. You could not put women in a placebo group if they're overtly hypothyroid. But I think there is broad consensus that these are unequivocally women who need treatment and that we can improve outcomes when we treat. So finally, that gets us to sort of the subclinical hypothyroidism and hypothyroxanemia group. Again, about 3.5% of women may be subclinically hyperthyroid. So this is the largest group of women that you're going to identify if we were to do universal screening for thyroid dysfunction for all pregnant patients. And we have a whole host of observational data. Now, this is just an example from one meta-analysis that demonstrate that women who are subclinically hypothyroid in pregnancy have a higher risk of a number of adverse obstetric outcomes. These include pregnancy loss, placental abruption, preterm rupture of membranes, neonatal death, and not in this meta-analysis, but in another recent one, preterm delivery. So there are adverse outcomes from the obstetric point of view. And we think from, again, a large number of studies with fairly consistent findings that having subclinical hypothyroidism and having thyroid autoimmunity, a detectable TPO antibody, increases the risk for those obstetric adverse outcomes higher than having just the subclinical hypothyroidism alone or just the thyroid autoimmunity alone. And we also, in thinking about mild thyroid failure in pregnancy, need to think not just about the obstetric outcomes that are of concern, but also of the outcomes for child brain development. And certainly, particularly in the first trimester of pregnancy, thyroid hormone that goes to the fetus is only coming from the mother. The fetal thyroid hasn't developed yet, and it's critically important for the fetal brain development. So maternal hypothyroxanemia and overt hypothyroidism, any condition where maternal free T4 is low in early gestation, does seem very clearly to be linked to lower child intellectual development down the road. The problem is, we think there are adverse outcomes associated with even subclinical hypothyroidism and hypothyroxanemia in pregnancy, but we don't really have data demonstrating a benefit for treatment. I think we haven't really had the right trials yet. There are, of course, 2 very large New England Journal trials, one led by John Lazarus in Europe, one led by Brian Casey in the US, that set out to examine whether treatment with levothyroxine for subclinical hypothyroidism or hypothyroxinemia in pregnancy improves child IQ. Both of those trials failed to show an improvement with treatment. I would argue that both of those trials have some methodologic flaws, so I'm not sure that they're the final answer on this question, but they did not show a benefit. We have some smaller trials, particularly 2 sort of recent paired trials from Faridun Azizi's group in Iran that demonstrate that there may be a benefit for preterm delivery if women who are subclinically hypothyroid with a TSH greater than 4 at baseline get levothyroxine starting in the first trimester. But we don't really have unequivocal evidence of benefit for treatment of mild hypothyroidism, and we don't really have any evidence of benefit at this point for maternal hypothyroxinemia. And I think you're going to hear more about this later on, so I'm not going to dwell on it, but the American Thyroid Association recommendations around treatment of subclinical hypothyroidism in pregnancy recommend kind of a stepwise approach where if there's a high TSH in a pregnant woman, that we'd advocate checking a TPO antibody and then framing decisions about whether or not to treat with levothyroxine based both on the degree of TSH elevation and on TPO antibody status. And the 2 groups that we thought unequivocally probably should be treated is any women with a TSH greater than 10 in pregnancy and any women with a TSH greater than 4 in pregnancy if she also has positive TPO antibodies. And we actually recommended against treatment of isolated hypothyroxinemia in pregnant women because there really aren't any trials right now demonstrating a benefit for treatment of that condition. And because it's very difficult to understand what appropriate free T4 thresholds would be for defining this entity because assays vary substantially for what free T4 levels look like over the course of gestation. And that was the American Thyroid Association's take on what we should do about hypothyroidism in pregnancy. Our obstetric colleagues in the US, the American College of Obstetricians and Gynecologists, look at the same data and came to different recommendations about what we should do, whether we should treat subclinical hypothyroidism or not. And they just say if it's overt hypothyroidism, you treat, and if it's subclinical hypothyroidism, you just don't. So we don't know. And I think that, as I will talk about in a moment, really makes it challenging to understand what to do about screening. Now, the one group that's a little bit different and where there's a whole separate set of data are women who are infertile who are going to undergo in vitro fertilization or other assistive reproductive technologies. And here we actually have 2 positive, small, randomized clinical trials. This one from Endocrine Practice is actually, these are data from Egypt. And this was a small trial in which 70 infertile women with a serum TSH preconception that was greater than 4 and normal free T4 were randomized to levothyroxine starting before the IVF and continued in pregnancy versus placebo. And they found that the treatment with levothyroxine in these women increased clinical pregnancy rates, decreased miscarriage rates, and therefore improved live birth rates. And a very similar trial published a year later, another small one, randomized 64 infertile women with the same thyroid function parameters, again to levothyroxine, started at the time of the in vitro fertilization and continued throughout pregnancy versus no treatment. In this trial, the clinical pregnancy rates were not significantly improved with the levothyroxine therapy, but miscarriage rates were lower, and therefore there was also an improvement in live birth rates. So the ATA does recommend pretty unequivocally that preconception, specifically for those women who are going to undergo in vitro fertilization or IVF with ICSI, should have TSH testing and should be treated if there's even subclinical hypothyroidism present. So, with regard to whether identification of conditions results in a beneficial intervention, I think the answer is unequivocally yes for overt thyroid dysfunction. I think the answer is probably unequivocally no for subclinical hyperthyroidism, no right now for isolated hypothyroxinemia, although I think more studies are needed, and we're not sure for subclinical hypothyroidism. So with regard to then, if we think screening for all pregnant women is beneficial, would it actually be cost effective? And here, I think the best study to look at is this one from Christy Dossio and colleagues. So the overall objective of this paper was to do a cost effectiveness analysis for treatment of subclinical hypothyroidism in pregnancy, or sorry, for screening of subclinical hypothyroidism in pregnancy. And they looked at a universal screening strategy compared to a risk-based sort of testing only high-risk women strategy versus no testing. And they tested with a strategy which would start with both TSH and TPO antibodies. They predicated this on the likelihood that testing, finding these conditions, and intervening with levothyroxine would reduce rates of miscarriage and preterm delivery and would also reduce missed diagnoses of postpartum thyroiditis. I don't think that the overall paper makes a whole lot of sense to me because I don't think we really know that treating subclinical hypothyroidism actually reduces miscarriage or preterm delivery rates. That really has not been definitively shown. And I'm not sure how important it is to avoid missing the diagnosis of postpartum thyroiditis because most of the time that's going to resolve on its own if we don't intervene. But what I do think is helpful with this study is that they did a sensitivity analysis in which they only looked at whether it was cost effective to screen for and treat overt hypothyroidism in pregnant women. And they found that using this testing strategy in their model, that it probably would be. That risk-based screening, just the high risk women getting TSH testing, and a universal screening strategy, both would have acceptable cost per quality adjusted life year. For a universal screening strategy in, I guess, 2002 US dollars, that cost would be about $7,000 per quality adjusted life year. And in general, in thinking about screening tests, anything that has a cost effectiveness that is less than the $50,000 per quality adjusted life year rate is considered potentially cost effective. So financially, this might make sense even if we're just looking for the overt hypothyroidism. But you have to remember that there are not just financial costs involved, and that there are, I think, also very significant non-monetary concerns if we're going to test millions and millions of women around the globe for TSH when they're pregnant. And the first is just, I think there's some risk, given that there is some nuance to the interpretation of thyroid function test results in pregnant women, and that you do need to understand how those tests shift throughout gestation. I'm not sure all providers out there really know how to interpret results appropriately, know that you can't just use the non-pregnancy laboratory reference ranges for these tests, and there's a risk for misinterpretation and perhaps inappropriate therapy. There's certainly a risk of overdiagnosis as well, and I think it depends a little bit on your perspective about subclinical hypothyroidism. If you believe that's something we should be finding and treating, we're going to find a lot of it. If we test all women, that's mostly what we're going to find. And depending on your testing strategy, if you test with a free T4 as well as a TSH in the screening approach, you're also going to uncover a lot of isolated hypothyroxanemia. And I am not sure right now that identifying those conditions really benefits patients or providers or the fetus, because right now we're not sure that if we identify those, we have a treatment to offer. So if I'm going to find a lot of women in my practice who have subclinical hypothyroidism and then tell them, well, I'm sorry, this condition is associated with adverse outcomes, but we're not sure we have any intervention that can help, this causes a lot of patient anxiety. I think it causes a lot of provider anxiety as well. And so I think that's important to think about in terms of a cost, even though it's not a financial cost, if we're really going to have a strategy where we're testing every pregnant woman. So having said all that, I think we do have a reliable and readily available test. It does require some nuanced interpretation. I think the condition is prevalent enough to potentially be worth screening for, again, particularly if we're focusing on the 0.5% of women with overt hypothyroidism. By contrast, though, something like gestational diabetes has a prevalence of maybe 2 to 10%, at least in the US population. I mean, often what we're testing for routinely in pregnancy has a prevalence that's a little bit higher. I think we can intervene in overt hypothyroidism. I'm less convinced that we're going to find asymptomatic women with other forms of thyroid dysfunction where we can intervene and make a difference. And mostly if we test all pregnant women, we're going to find subclinical hypothyroidism, isolated hypothyroxanemia, where we're really not sure that there's an intervention right now that helps. So in light of all of that, what are different organizations recommending? And it's really, I think, because the data don't really, they're not conclusive. There's a lot of shades of gray here. That recommendations are all over the place. So ACOG, the American College of Obstetricians and Gynecologists, really recommends against testing in most pregnant women under any circumstances. They really only want us to test if there are clear symptoms of thyroid dysfunction or a known history already of thyroid disorders. At the other end of the spectrum, in Poland, in Spain, in China, a huge country, there are recommendations for universal screening for TSH testing of every pregnancy in early gestation. The European Thyroid Association has a guideline that really supported universal screening, and the US Endocrine Society had a guideline where they actually couldn't decide, and the panel split right down the middle with half recommending universal screening and half recommending the other strategy, which would be case finding. And that's sort of the middle ground, is a strategy where you don't test every pregnant woman with the TSH, but you test those women who are particularly at risk for having hypothyroidism. Now, the American Thyroid Association, we really felt we couldn't recommend either for or against universal screening for pregnant women with TSH. We just didn't feel the data was there, and I still feel that that's the case. We also said there was insufficient evidence to recommend either for or against universal screening with TSH preconception, with the important exception that I talked about, that those women who are going to undergo IVF should have a TSH checked. It's potentially a treatable cause of the underlying infertility, and even mild hypothyroidism, there may be a benefit of treatment there. And we do not recommend screening with free T4. I think if anybody's going to do a screening strategy, it makes much more sense just to start with the TSH and get a TPO and a free T4 as a reflex if the TSH is abnormal, because we don't really want to be finding the isolated hypothyroxanemia because we're not really recommending therapy. However, I think it's important not to miss that 0.5% of overt hypothyroidism that you would find if we're testing those high-risk women. And so the ATA has an intentionally very broad set of case-finding criteria that we have recommended. So that would include TSH testing in early gestation for certainly any woman with known thyroid dysfunction. I think that's a no-brainer. Or signs or symptoms that could be related to thyroid dysfunction, which I think is almost any pregnant woman, honestly, if you ask enough questions. Most pregnant women will have at least one symptom that could potentially be linked to the thyroid. Certainly would want to test any woman with antibody positivity, TPO antibodies, or known presence of goiter, a history of thyroid surgery, a history of head or neck radiation, anybody with a personal or family history of any form of autoimmunity, age over 30, which gets quite a lot of women because the prevalence of hypothyroidism increases with age. The one in yellow is multiple prior pregnancies because there's a higher prevalence of hypothyroidism in women who've been pregnant more frequently. And so more than 2 previous pregnancies, or at least 2 previous pregnancies, we put in as a new criterion for case finding. Women with a history of miscarriage, preterm delivery, infertility, because as I've shown you, those things are linked to even mild hypothyroidism. Morbid obesity, women with a body mass index greater than 40, also at higher risk for TSH elevation. We recommended treatment. Anybody using medications that could cause thyroid dysfunction. And then something that probably doesn't really apply necessarily either in the US or in Egypt, but women living in severely iodine deficient regions. And this case finding strategy hasn't really been tested very much. This was published in 2017. The only study I know of so far that has actually looked at the effectiveness of this strategy is this one, which was published last year. This is a retrospective study in 1,800 women in a single center in Belgium. And they did thyroid testing in everybody, and then they looked to see what proportion of women with hypothyroidism would be identified using a universal screening strategy where everybody gets tested up front, compared to using the case-finding strategy in which you target testing just to the high-risk women. What they found was that using the current criteria, about 2/3 of women would be defined as high risk, and I think that was sort of intentional when we wrote the guideline for that. So the majority of women would get tested even if you do a more limited strategy. They found about the proportions that you'd expect. About 4.5% of women and about 0.5% of women had subclinical versus overt hypothyroidism in the sample. And they found, as you would expect, that universal screening will capture more cases of both overt and subclinical hypothyroidism than a targeted testing strategy. But actually, the difference was only significant for subclinical hypothyroidism, which I'm not sure we need to find. And the difference in the number of women identified with overt hypothyroidism, which I think we do want to find, was not statistically significant. And that's, I think, reassuring, but a finding that unequivocally needs to be tested in larger centers and in larger sort of studies across different populations. So with that, I'll thank you for your attention, and I believe we've got some time for questions.